Welcome to another episode of the MEGIN Spotlight series. Today we are delighted to have Dr. Sarah Weatherspoon, a neurology specialist at Bonheur Children's Hospital in Memphis, Tennessee. Bonheur is the only comprehensive pediatric hospital in the region. For our audience, it is a 255-bed facility located in the Memphis Medical District. Bonheur has been recognized among the nation's best children's hospitals by US News and World Report for 9 consecutive years. Dr. Weatherspoon also works very closely with Dr. Jim Wheelis, the Chief Neurologist and Co-Director of the Neuroscience Institute at Bonheur, who's a great advocate of MEG technology and actually has been on our spotlight as well before. Hi, Dr. Weatherspoon. Nice to meet you. Nice to see you.
Great to see you as well.
So let's start with our first question then. What started your interest in MEG and how has its utilization evolved in your epilepsy clinical career?
Well, I first was exposed to MEG during my residency and fellowship training, which I did at Cincinnati Children's. And MEG there was a vital part of all of our pre-surgical evaluations, any phase 1 evaluation that we did. And at that time, Dr. Doug Rose was in charge of the MEG, and I really appreciated when we would sit around a round table to discuss those surgical cases in our epilepsy surgery conference. He would present the MEG data and go into a lot of really granular detail about dipole analysis, functional mapping that added a lot to those discussions we were having as we anticipated surgery in these challenging patients. And there was no discussion that was had about any patient that did not include a MEG. Essentially, as I can recall. And I realized, or I came almost to take for granted, that that was a fundamental piece of how we approach deciding how to plan an epilepsy surgery or a phase 2 evaluation for a patient. So that was my first exposure to MEG and really fundamental to my fellowship training. And then when I was deciding where to take my first attending position, once I completed my training, I was looking around at different centers. And it was really important to me to go to a center that also had an MEG and had that technology available. So that led me to Bonheur Children's Hospital here with Dr. Jim Wheelis. And here we've also, again, incorporated MEG into our surgical evaluations. And so, again, I've really become so even more appreciative of that technology and what it adds to any patient, especially in the pediatric patient population, their surgical evaluation. So it's just kind of part and parcel of what we do when we think about where are seizures coming from in a child's brain.
That's great. I mean, it's nice that you've been exposed so early on in your career as well. That helps a lot, I think, too, doesn't it? How do you describe MEG to your epilepsy patients and how an MEG scan might benefit their epilepsy care plan? I mean, how early in a patient's care plan may they be recommended to have the scan?
So when we're bringing patients into our epilepsy monitoring unit, that is always a consideration I have as I'm thinking about what tests do I need for this patient. Is MEG needed for a patient? And so how I'll talk about it with families is I'll say, it has some similarities to EEG in that it lets me look at abnormal activity in your child's brain, but it has this added benefit of being able to really hone in on a more specific area in the brain in the sense of not just which side or which lobe of the brain, but really down to a gyrus, a very small area. And it may also help bring to the surface areas that I can't detect with my EEG all the way out on the scalp, that the MEG can bypass some of those barriers to do a really deep dive into looking at that abnormal activity. And so that's how I talk about it with families. I also make sure I talk about how it's non-invasive. Families often automatically worry about radiation when they think about anything that we're doing that might, have an acronym to it or be something they're unfamiliar with. That's always when they're concerned. So I always try to put those concerns to rest, that it's non-invasive, minimal risk sort of test. And yes, in pediatrics, we often have to use some sedation, but we have special protocols to make that safe for patients as well, to where we can get the data we need and they can wake up safely shortly thereafter and go on about their day. So that when I'm talking with families, those are things that definitely come up. And then when I'm thinking about when do I need to use a MEG, it's always high on my priority list, really, in a lot of patients, especially coming into the EMU, whether it's a first-time visit to the EMU or a lot of second opinions that we get from outside of our region come, and I may not have all the information in front of me when I've got a second opinion. I may not have every aspect of their records from the other institution. So I think if there's any possibility they could benefit from having a MEG, if it could help inform me in giving them more information about their epilepsy, then I usually go ahead and obtain that test when they're there.
That makes a lot of sense. And then talking about the EMU, can you tell us about the inpatient EMU or epilepsy monitoring unit workflow at Le Bonheur? For the patient, what is the process and what modalities are they exposed to?
Right. And this really comes down to our fantastic coordinators, both the EMU coordinator that we have and our MEG coordinator, who relay this information to families before they even come to the EMU about expectations about what we might be doing. And once they're there, having our MEG coordinator explain to a family what is a MEG in layman's terms that are easy to wrap their minds around and kind of, again, allay any concern they have. So when these patients come in, again, it might be my patient from clinic who has tried and failed 2 or more seizure medications. And I'm thinking about, is this person a surgical candidate, or is there something that I'm not quite understanding about their epilepsy where more evaluations would help me? Or I may be seeing one of my colleagues' patients who, again, has developed intractable epilepsy. Or again, one of these second or third or otherwise opinions coming from another institution, whether it's for surgical evaluation or just to get a better handle on what kind of epilepsy they're having, what might be a better matched treatment for them. And so when I'm looking at this patient cohort that's coming in on a week where I'm on the EMU, I'm looking at my checklist of tests that I might want to get. And MEG is one of those. And so I'm always thinking to myself, is MEG something that would benefit this patient or help me better understand their epilepsy? And if so, then I will go ahead and, check the box that that's a test that we need to get. And so we work closely with our MEG director, who is always tries to make it flexible in terms of what day we may want to get it or what other things we may want to do. For instance, so if somebody comes to the EMU and their EEG is not showing a lot of activity initially, and we get the MEG at the beginning of the week, we may not get as much information for dipole analysis at that point. But let's say I'm watching that patient through the course of the week, maybe holding their seizure medication to facilitate capturing seizures. And over the course of a couple of days, their EEG becomes more active, more epileptiform discharges. Then I coordinate again with our MEG coordinator, our MEG director, saying, could we come back and maybe do another MEG? Now I'm seeing more activity. I've got this patient here who's not on medication. I can't just send them home like this or bring them back later like this. Now that we're in this safe EMU setting, can we repeat a MEG even later in the week? So sometimes we'll do more than one MEG on a patient as we learn more about what their brain activity is sensitive to and what things we can do to really maximize the results we're going to get from an MEG. So that's how our workflow may work, especially during the course of a week, especially as it relates to MEG. And then I'm very fortunate to have folks like this who are processing the data who can give me those results rather quickly, sometimes even within the week, where I can go back to the patient while they're still there, especially a patient who maybe, again, has traveled several hours to be here. And I can go ahead and start to share some preliminary ideas and results about, yes, you may be a surgical candidate. Here's what I'm thinking about. Or, oh, what we thought was a generalized epilepsy, we actually are seeing more evidence it might be a focal epilepsy. There might be a better treatment we could try that wasn't previously considered. So having that MEG back rather quickly and being able to work with our team so closely helps me get those results to a patient very rapidly and make good decisions to move things forward in their epilepsy care.
Yeah, I must say, having met the team, I think it's an excellent sort of way of working at Le Bonheur. It was very obvious when we came to visit recently. So for the clinicians then, how do you work together to assess the data from all the modalities and ultimately make clinical decisions on patient cases? You were talking about Dr. Wheelis, and I guess you have conferences. What happens next?
So we often, like a lot of places, a lot of centers will have a weekly epilepsy surgery conference. So this is attended by all the different specialists who would be involved in touching that patient's care in some form or fashion. So the neuropsychologist, the neurosurgeon, the neuroradiologist, all of the epileptologists to give all of their individual input after assessing the data, as well as the MEG director. And so having all of those folks around a table as the person like myself, it's my patient, is presenting all this data, and then to be able to go around and get everybody's input, or maybe say, hey, let's get another test, or hey, maybe let's repeat the MEG, or et cetera. The other things we may want to consider is an important piece of how we approach those patients. And then we move forward with saying, is this person, for example, a surgical candidate or not? Would they benefit from something like stereotactic EEG, or do we need to think about other modalities like that we might use, implantable devices, for instance? And if we think stereotactic EEG is a viable option for a patient, then always a piece of that conversation is, where were the MEG dipoles? And let's be sure that we cover those densely with stereotactic EEG. And for our patient population, not only do we have just kind of focal epilepsy, it's intractable, but we see a lot of patients who have brain tumors due to our relationship with St. Jude Children's Hospital here. So we see a lot of patients who either have a tumor and seizures, and they're looking at resecting that tumor. And we want to know, where is their functional aspects that we need to be cautious about in resection? Where might their dipoles be, that if we're going to resect the tumor, what additional tissue maybe around the tumor is important to assess as well. So that becomes an important patient population for us. But even down the road, somebody who's had a brain tumor resection, we see a lot of cases like that, who now are coming back. Yes, the tumor's gone, but now there's intractable epilepsy. And what do we do about that? And what I've found is looking at the MEG can be helpful in deciding if there's a dipole cluster, where is it? Is it, anterior resection margin? Is it somewhere else along the resection margin? Is it somewhere different? Maybe there's dual pathology, and the MEG dipoles can help highlight that need, to where we're making sure we're assessing all the different aspects, not just a resection cavity, but other areas of the brain that might be involved in that seizure network that we need to address if we're thinking about something like stereotactic EEG. And then the other patient population we see a lot of is patients with tuberous sclerosis. So as you know, these patients often have multifocal epilepsy, or multiple areas where they could at least potentially generate a seizure from. And so we find those MEG dipole clusters that may be in or around a particular tuber help guide our SEEG planning and making sure that we cover those areas as well as other tubers of interest. We know that resecting MEG dipoles is going to give that patient potentially better long-term seizure control. So our neurosurgeon is really fantastic about saying, okay, where are those MEG dipoles? And let's make sure we put even additional stereotactic EEG coverage there. And that's been really helpful in a lot of our cases.
That's amazing. Thank you. So when we visited recently, you presented a patient case where MEG data gained during a patient's journey made a vital difference to the patient's outcome. Could you describe the case in a little bit more detail and how MEG data has allowed for this improved clinical outcome?
Yeah, absolutely. That has been one of the most interesting cases I've encountered. It was a 9-year-old boy who'd been born a little bit early, about 34 weeks, and he'd subsequently had an intraventricular hemorrhage, which we know can happen. And it was more on the right side of his brain. And he came to us again as a second opinion. He had developed intractable epilepsy with seizures starting around 5 years of age that were clearly focal seizures with impaired awareness at that point in time. And they never really completely responded to medication. And then within a year, he went on to develop ESES, or electrical status epilepticus of slow wave sleep, which we know is a particularly malignant EEG pattern that can be associated with developmental regression and stagnation, which was in fact what happened to him. His development just kind of stopped where it was at about a 5-year-old level, and even lost some skills. And the physicians who were treating him previously tried a lot of great pharmacologic options for him. That physician referred him to a different epilepsy center who looked at the EEG, it sounds like, and said, you know what, we don't even think this is that this person would be a good surgical candidate. Things look like they're coming from the whole brain at once, for instance. So when they looked at that ESES pattern, it looked like the entire brain was involved, not just one focal area. And so that patient was told, you know what, we're not even going to do an MEG. There's too much going on, or it's too diffuse of a seizure network. So, we think you should continue with pharmacologic options, which clearly weren't working for him. He'd been through about 8 of them. So at some point, they got connected with our center. And when he came, I got the MEG. Again, I didn't have a whole lot of information about him, but I thought there's enough going on here. I think an MEG could help me. And yes, when I looked at his scalp EEG, it was very diffuse. When he would go to sleep, he would have continuous spike and slow wave that looked like it was just consuming all of his brain activity everywhere. And then the seizures he was having, even though they were short, maybe 5 seconds, he would have hundreds of them a day, and he was collapsing with them. He would have a little bit of clonic activity and then just collapse to the ground, to the point where he wasn't able to ride a bike anymore. And the family had stopped taking vacations because they were always worried that he might injure himself or that his seizures might become explosively worse and they wouldn't be close to a good children's hospital, get him emergent care. So they'd really contracted what they were able to do as a family because of his epilepsy. So we captured these seizures, and what maybe had looked kind of diffuse, we saw there was a little bit of a lead-in on the right side. And then we got the MEG. And what was fascinating to me about the MEG is when even though it was done with anesthetics, because he's a little bit wiggly and he needed to be still, that EEG pattern when he was under anesthetics was an ESES pattern. He had spikes everywhere. It looked like it was the whole brain was involved. But when I got the MEG result back and talked with our MEG director, there was a very tight cluster. Those actually localized extremely well to the right temporal, one of the right temporal gyri. And it was really remarkable to think, wow, this EEG scalp process that looks so diffuse on an MEG is quite focal. And that led us to think this person might be a good candidate for at least stereotactic EEG. And so we moved forward with that phase 2 evaluation. And after going around with our epilepsy surgery conference, going around the table, getting everybody's input, making a step-by-step plan with a neurosurgeon about what trajectories we wanted for our stereotactic leads. And again, we did a very heavy coverage of where those MEG dipoles were, but I also sampled many other places because we did still suspect this was a big network, potentially, a diffuse network that we hope surgery can help, but we don't know yet. And what we found once we had those stereotactic EEG leads in place is that the seizure lead on for these numerous seizures he had every day were coming from one discrete area, almost 2 or 3 contacts total out of the, plus 100 that we had placed. Our neurosurgeon was able to go back in, resect this very selective area. And, like we do oftentimes as epileptologists, we prepare the family for, this is what we think is going on, but it's very possible and if not very likely, he still may have seizures. So we prepped them for that. And he came out of the OR. He did great. He recovered. He was able to go home after a couple of days. And the family emailed me 30 days later and said, he's been 30 days seizure free. We haven't had this period of seizure freedom in as long as we've remembered since this process started. And now we're going on about 2.5 months and he's still seizure free. Again, a child having hundreds of seizures a day who was told he was not even a surgical candidate, who that potential for seizure control would have been missed. And the MEG really guided what we did. And the dipoles lined right up with where the seizures were coming from on the stereo EEG. So really an incredible case of not only did he have focal epilepsy, but he had diffuse sorts of onsets as well as an ESES pattern. And we know more and more data that there may be surgical options for ESES, which otherwise is a very difficult pattern to control. And this patient's really benefited greatly. And a lot of that is thanks to getting the MEG that he'd been previously told he wasn't even a candidate to have MEG at another center. So that's gone remarkably well. And we're looking forward to using that more in cases similar to that.
I think these kind of stories are really rewarding for us to hear, that this is sort of possible with MEG technology. So I think that's great. So we're going on to our last question then. So we're often asked, because we go to a lot of advocacy group meetings and talk to patients themselves, and we're often asked about the difference between EEG and MEG. Could you give us some examples where MEG provides superior data? In which scenario would you use maybe even both modalities?
Right, absolutely. So, EEG has its benefits. It's very important for capturing seizures, for long-term monitoring, but its limitation is that it cannot hone in on a very precise area necessarily. We may be able to get things down to a hemisphere or a lobe, or have suspicion about a particular area within, let's say, a frontal lobe, but it can't be as precise as we'd like it to be. And so the MEG definitely presents benefits in the sense that it can pick up on areas that are very deep, whether it's the insula or orbitofrontal cortex, which again, very mesial, very deep tissue that EEG may just show maybe at best subtle slowing sometimes during a seizure, and interictally may be silent, but MEG has the potential to pick up on that for patients who, again, maybe we were told, you're not a surgical candidate, the EEG doesn't show anything. So MEG, again, can detect those deep sources of abnormal activity. In addition, we've been able to get an ictal MEG. That's been incredibly helpful in the handful of cases I can think of that I've had where, again, the EEG on scalp may look quite diffuse, but on MEG, especially if we have the rare opportunity to capture a seizure with more hypomotor activity, can really well localize the seizure onset even to help direct our phase 2 evaluation. And then finally, that functional mapping is such a critical part of what we do in pediatrics, because as you can imagine, a 5-year-old, even an 8-year-old, necessarily can't always do bedside stimulation. Once they have intracranial EEG electrodes in, having them read may not be possible, or having them identify objects if they have other developmental abnormalities may be very difficult to get reliable information about functional mapping at the bedside in that way. So, and of course, in pediatrics, we can't typically do a WADA. That's not always an option for young children. So MEG provides the benefit of doing non-invasive functional mapping, especially things like language lateralization in a very young child who may have intractable epilepsy or have a tumor that is going to have to be resected. And we're looking at where should those resection margins be, if we can assess that, and using our MEG to help with the functional assessment in those patients who otherwise wouldn't be able to cooperate typically in the awake state, but even in a sedated state, we can get good data about language and sensory motor mapping without having to put that child through an undue process that would be stressful, if not just unreliable at their age. So we've seen so much benefit in being able to use that in all of those patients that EEG just can't do that level of functional mapping, obviously, and it can't give us the dipole analysis that MEG can for these potentially diffuse processes that end up being focal, or deep-seated focal sites that don't show up on scalp EEG. So I feel like we could be potentially missing a lot of patients who could benefit from epilepsy surgery, which we know is one of the most helpful things we can offer when medications have failed in terms of even being potentially curative. And there's not many things that are curative in pediatric neurology, unfortunately, and that's really what got me interested in epilepsy surgery in the first place, is the ability to really change the trajectory of a child's lifestyle and development by intervening with epilepsy surgery. And MEG is a critical piece of that, particularly in pediatrics, but also in adults.
Thank you, Dr. Weatherspoon, for your time today. This has been incredibly insightful and discussion around how you're utilizing MEG in epileptology at Bonheur. Thank you again for your time today. We really appreciate it.
Thank you so much for having me.